information to you. So thank you, Dr. Gruenewald, for joining today. We're thrilled to have you, and we'll let you take it from here.
Thank you very much. Appreciate the invitation here, and let's get started. So, stopping eating and drinking by advance directive. I have no conflicts of interest to report, and emphatically, the views that I'm talking about are my own and don't represent those of any institution. A few objectives. One of the things I'm going to mention briefly is sort of a general context of how to approach conversations when a person requests hastened death. Then I'm going to apply that rubric to stopping eating and drinking by advance directive, which throughout the talk I'll refer to SAID by AD as an abbreviation. So, of course, ethical arguments are going to be a key focus of the talk, with an emphasis on dementing illnesses. We'll talk about the key components for directives for SAID by AD. What are the challenges in actually bringing a plan for SAID by AD to fruition, and some approaches that might mitigate those challenges. But first, let's start with it. A case. This is an 89-year-old woman, a retired nurse, and she has a 2-year history of progressive memory impairment and was recently diagnosed with amnestic mild cognitive impairment. She has a long history of not wanting life-sustaining treatments at the end of her life, and including in dementia, even especially in dementia. And she's become more and more distressed about her memory loss. She is now thinking of seriously considering hastening her death. She knows about stopping eating and drinking as a modality, or she's thinking, maybe some other way, unspecified. So she comes to medical evaluation. There's a conversation with her primary provider. She is not depressed, and she demonstrates full medical decision-making capacity. She's able to describe why she is considering VSAID, and this seems consistent with long-held values. So the next step is a family meeting. And what comes to light is she's especially concerned about being a burden on her family, both financially, she wants to leave a legacy, and also the burden of caregiving that she worries might fall to the family members. So the family offers that that's not their view at all. So in fact, they consider her to be a great blessing to the family. They note how she continues to contribute to the well-being of the other people around her, both family and friends and colleagues, former colleagues. She has been a planner all of her life. She has long-term care insurance. She's already receiving some degree of assisted care. And it's really the family's privilege and pleasure to continue to be a part of her life. So somewhat grumpily, she accepts the family's request that she just kind of settle in, enjoy her life, and when the time comes, allow others to care for her as she may need. One outcome is completion of a dementia directive, and we'll talk a little bit more about these directives as we go forward. So Ms. G is my mom. And just to mention that I wrote about the very end of her life in JAMA, A Piece of My Mind. So for those who are interested in that part of the story, it's published. So what are we talking about here when we say SAID by AD? How is that different from VSAID? These are different. And when we talk about advanced directives stopping eating and drinking, we are withholding or proposing to withhold oral food and drink from a person who has permanent loss of decision-making capacity in advanced dementia, notably. And this is generally based on a prior directive that was completed while the person had capacity. So by contrast, VSED is the contemporaneous stopping of eating and drinking. It's voluntary and deliberate. It's a choice to hasten death that is made by a person who now either has a serious illness or it's anticipated that sometime soon they're going to be affected. And so they decide at that moment it's time to stop eating and drinking. So the dilemma here in people who are either already affected by early dementia or who have mild cognitive impairment and are anticipating issues in the future. Many of these folks wish to avoid a prolonged dying in a state of advanced dementia. And some of these folks are starting to think about dying by suicide or stopping eating and drinking while they still can during this window of opportunity that may close at some point in the future and possibly sooner rather than later. But that decision involves a potentially enormous cost to preemptively hasten death, in that one would be foregoing some possibly at least satisfactory or maybe even high quality years of life yet to live. So then the flip side is that if you don't act, there is risk of living for years with advancing dementia. So let's talk about the options that a person who is worried about dementia and its progression might have in this situation. Now, I don't mention here in the spectrum of options, but it's worth noting that many people just accept that this is kind of the way things are going to go, that they are going to lose control over their dying process. But many of these folks find that unacceptable. So they could pursue preemptive dying by suicide or VSED while they still have capacity, or they can wait until the quality of life reaches the point where they believe that quality is no longer acceptable, and hope that there is some mechanism to keep them from living on and on after that point has been reached. So the thing is that in dementing illness, usually there is no life-sustaining treatment to withdraw in most cases. And so as we'll talk a little bit more, in other conditions, a lot of times there is a life-sustaining treatment to withdraw, and that can be used as a mode to say, I'm ready to die, and I refuse further treatment. So we're going to talk a little bit about comfort feeding only, or CFO, and minimal comfort feeding as potential avenues that people consider, as well as SED by AD. So one important point here now is that some people, if they could reasonably be assured that their directive for SED by AD would be implemented, they might prefer that option to any of the other options on the table and to that preemptive death either by suicide or VSED. So why not rely on a traditional directive? A lot of people don't know that there are other options like dementia directives and in particular directives for stopping eating and drinking in the future. But traditional directives really don't address the concerns of those who worry about advancing dementia. And then their providers often will just continue the same modality of medical care as in the past, even though the dementia is progressing. So it's clear that many people, when asked, would actually prefer that the intensity of medical interventions be ratcheted down as dementia progresses, and a focus on comfort and quality of life be ratcheted up in that time. So enter the dementia directives. These directives, generally speaking, call for a change in the care plan when certain milestones are reached, either cognitive or functional milestones, but not all of these directives address oral nutrition and hydration. And the directive that my mother completed in 2014 did not address oral nutrition and hydration. So what about comfort feeding only? What is that? It is a plan to allow the individual, as they approach the end of life, to eat or drink as much or as little as they appear to desire. And generally speaking, that involves offering assisted, scheduled hand feeding, as long as the individual is not showing any signs of distress around being fed and offered drink as well. You know, those might include coughing or choking or turning away from the spoon that is offered. And the goal of CFO is comfort, as the name implies. It is not to keep the nutritional state metabolically adequate. And then feeding should be stopped if the person appears distressed. And this was originally proposed in 2010. And since that time, in the geriatrics community, at least, it's often considered a best practice in the care of people as they approach end of life, including those who have advancing dementia, although not everyone accepts that CFO is a best practice in advancing dementia. Importantly, CFO was never intended to be a modality to hasten death. And as we have seen in expert opinion and experience of those who have seen many people traverse the process of dying with CFO, those individuals can live for months and even years in many cases. So for those who want hastened death, it's really not a goal concordant practice. In recent times, a variant of CFO has emerged that has a different goal in mind, known as minimal comfort feeding. So what are we talking about here, and how is it different from CFO? So as we just noted, in CFO, people are allowed to take as much or as little as they might appear to want. And so CFO also defines the upper limit of what is acceptable. But in MCF, or minimal comfort feeding, we are only providing the minimum amount of oral food and drink needed to assure that the visual evidence of comfort is achieved. So there's no scheduled mealtime here, and only the smallest amount of water and food is provided when the person appears to have signs of distress. And then once those signs of distress are mitigated, then the food and drink is stopped again. So this approach is only appropriate for those who have already in the past, while capacitated, expressed a desire to avoid living in a state of advanced dementia. There's no research on MCF, so we don't know things like, does it actually reduce survival time? And if it does, by how much? Do people still live for many months, or is it more weeks to a couple of months? Nobody knows yet. But we can say that because this is a hastened death modality, there is a definite need, if you are contemplating initiating MCF, to have additional discussion with the surrogate and caregivers. So then we come to advanced directives for stopping eating and drinking. There are by now many examples available. And in the book that I reference here, in one of the appendices, many of these examples are collated. I want to highlight one example that I reference here from the Northwest Justice Project. So I gave this talk in 2023 to a different audience, And at that time, I noted that End of Life Washington and End of Life Choices New York had their own kind of individual advanced directives for SED. And subsequently, now, both of these organizations reference this particular advanced directive for SED from the Northwest Justice Project. So it seems to incorporate many, if not most, of the best practices that I'm going to be talking about. Now, on their website, they say this could be usable anywhere in the United States, but I think we need to have some more discussion about that as well. So I'm not going to talk about that specific directive. I did capture some screenshots and kind of went through it in the appendix to this talk, which we don't have time for, but I'm just going to run through now some best practices in constructing an advanced directive for SED. First, the person who is completing this directive must have decision-making capacity. So that has to be established. And then we talk about what's in the directive. Specifically, what are we talking about when we are withholding food and drink? It's not tube feeding only. We're talking about oral food and drink. And this is where many of the previous attempts to stop eating and drinking by advanced directive foundered and did not withstand legal challenge. It has to be very specific about oral food and drink. Then these directives will discuss CFO, whether that is acceptable under any circumstance. And if CFO is going to be withheld, it must be clear in the directive why we would be withholding a comfort measure. And people need to understand that if we are withholding a comfort measure, there may be some discomfort involved down the line, and people need to be aware of that and explicitly acknowledge they understand and want that to occur anyway. Then we should talk about assisted feeding. This assisted hand feeding, is that acceptable and under what conditions? Or should it be stopped when the person can no longer self-feed? Or does the dementia directive call for all food and drink to be withheld at some point? Then what are we talking about when we say at some point? We need to define the triggering events that will trigger the withholding of oral nutrition and hydration, as well as how the surrogate medical decision maker is to know when a trigger has occurred. So for example, we might say that when a fast stage of dementia has been reached, and perhaps the person is now no longer able to say more than, say, half a dozen words, then that might be the trigger. But it may be we will be asking a medical professional to make that determination. Or we might say that when I can no longer recognize my loved ones, then that should be a trigger. And then it would be the medical surrogate who is going to be making that decision. Importantly, the reasons and values that motivate the directive and a clear understanding of risks and benefits, what are the alternatives and the consequences of this choice, all must be documented clearly. And to amplify all of that, one of the best practices that seems to be very important in actually being more compelling to those down the road who may be called upon to implement the directive is if there is a video recording of the person discussing their own directive and why they want this, their reasons, their underlying values, that can be quite persuasive as an element of an AD for SED. So then we come to a central dilemma that we're going to spend a little bit more time on. What if the person appears to want, and I may have air quotes around want, oral food and drink, which is then contrary to the advanced directive for SED? So should the directive indicate that this current preference of the now incapacitated individual, should that current preference override the directive and in effect overturn it? Or should the caregivers be directed to proceed anyway with stopping eating and drinking and removing the food, which is known as a Ulysses clause, as Ulysses on his ship is sailing by the sirens and is called to direct the ship to founder on the rocks. Instead, it's like, I'm blindfolded, take me past anyway, no matter what I say. And should we, if it proves too difficult or impossible to implement the directive, should there be kind of a backdoor alternative to allow for minimal comfort feeding as an alternative? Then, in addition to the AD for SED itself, there must be another document appointing the healthcare agent, a durable power of attorney for healthcare. And in general, it's best to explicitly grant the agent the permission to use discretion and their own judgment in how to best to implement the directive and when to time the implementation of stopping eating and drinking. So one can see here the importance of choosing wisely who's going to speak on your behalf, and to recognize that this is a big ask and circumstances may look different at the time from what we might have anticipated in advance. Then we also need companion documentation, conventional advanced directives with other directions around life-sustaining treatment that we may want a POLST or MOLST or MOST document that specifies what should be done with code status, intubation, hospitalization, dialysis, and so on. Should antibiotics for pneumonia be given, knowing that eventually some people with dementia die by pneumonia or pressure sores and sepsis, those kinds of things. So having that kind of documentation in addition is important. So I want to transition now to talking about the legal status of these directives. It's uncertain. Bottom line, it's uncertain. And the healthcare statutes for these kinds of directives vary by state, and that is really important to understand. And the nature of the statutes in state law, some of them may be broad enough to allow for stopping eating and drinking by advanced directives. There is one state, Nevada, that has explicitly legalized SED by AD, and a few others appear to explicitly honor these advanced directives that are completed in other states, notably California and Minnesota. So if there is this kind of reciprocity understanding, then that could be useful. On the other hand, there are states that explicitly prohibit the withholding or withdrawing oral nutrition and hydration, including Delaware and Oklahoma. I made an attempt a while back to see about the state of Michigan, and I couldn't find anything specific. So that's kind of an open question for those of you in the state of Michigan. So there's no explicit judicial guidance on SED by AD, and it's unclear whether the directives themselves could be used to try and prevent the caregivers from offering food and fluids in advanced dementia. And that kind of sets up a kind of an oppositional dynamic in any case, and it's best if we can avoid that, I think, for the sake of the person who now is demented. So what we can say is that in general, advanced directives are to be honored, and the judicial guidance that is available supports the use of advanced directives to guide treatment decisions when capacity is lost. And now to the meat of the discussion as we talk about ethical issues. So is it ethical to implement these directives? Some arguments in favor. The rights to refuse life-sustaining treatment, including voluntarily stopping eating and drinking at the time, so contemporaneously said, while the person has capacity, those rights are established and are really based in the right to refuse any medical intervention, as well as non-medical bodily intrusions, or battery is really what we're talking about. And these directives are widely accepted and have been for decades as tools to ensure that when you lose capacity to make medical decisions, that you don't also lose your rights. And then we come to assisted hand feeding, when a person is no longer self-feeding or is having difficulty self-feeding. That has been argued that when we're talking about assisted hand feeding, we're talking about a procedure, and paid feeding assistants actually need to be trained, and there is an 8-hour training course minimum requirement to gain the skills to hand feed a person who can no longer feed themselves. And CMS stipulates that people with complicated feeding problems need to be fed by a licensed person, an RN or LPN. So this starts looking very much like a skilled intervention, and in that way, similar to other life-sustaining treatments. And so the distinction here is treatment versus basic personal care that is a right for anyone to receive. So that's the distinction that has been made here. And so the argument, therefore, is that refusing assisted hand feeding should be within the scope of advanced directives. So having said all of that, that doesn't mean that a clinician has to always honor a directive for SAID. And really the best practice that's been argued for here is that individual assessment of the request is necessary. And then if it's legally permissible, ethically appropriate, and practically feasible, then those requests should be honored. And if you can't honor the request, refer the person to a clinician who would be willing to work with that individual. Now let's talk about the flip side. These directives can be challenging to implement, and there may be substantial burdens associated with implementation, both for the surrogate medical decision maker and for the caregiver who is called upon to implement the directive. And these challenges can be greatly magnified if the person is still able to feed themselves, and if they appear to be enjoying the food, or that's the perception of the folks at the bedside, that they appear to accept and welcome the food and drink, then we can anticipate distress by the proxy decision maker and the caregivers. How to minimize that distress and improve the likelihood of adherence, it really falls to crafting these directives very carefully with detailed instructions on what to do in that event that the person seems to accept food and drink. And we should also say at this point that it would be inappropriate not to give guidance and support to the bedside caregivers. And it's really not their role to resolve the ethical issues without support. So let's talk about changing your mind. Can a person who is now demented and incapacitated, can they change their mind? It is well established that the person who has capacity can revise or revoke an advanced directive anytime they wish for any reason that they want. But by the time that these triggers occur, it's almost certain that they will no longer have capacity for medical decision making. They may be at some level able to communicate that they want food, or at least physiologically, they will open their mouth when the spoon is offered. But can they understand the relevant information? Can they reason around the treatments that are available and what options they have? Do they even remember that they have an advance directive? And can they appreciate the consequence of choosing, or apparently choosing, to eat, being that they are overturning the directive that they felt so strongly about in the past? So it's been argued that this is not a true change of mind, and sort of glibly, it's been said that these individuals no longer have enough mind to change. So they seem to understand that they want to eat, but not the context in which that action of eating and drinking is occurring within. So this whole challenge has been called the then self versus now self dilemma. What do we do with that? In a directive, some individuals will direct that their then self should rule, and that their wish to stop oral food and drink when a criterion or a trigger occurs should override the now self and their apparent desire to eat and drink in the moment. And so, as we have mentioned, this may cause some distress in families and caregivers when this apparent challenge to the directive occurs in practice. So the Society for Post-Acute and Long-Term Care, known as AMDA, in 2019, they evaluated this then self versus now self dilemma. And at that time, they recommended universal rejection of these directives in long-term care settings. And instead, practitioners were directed to continue comfort feeding. So in essence, they were saying, don't honor these directives under any circumstances unless the person appears to be in distress when fed, or they are actively refusing feeding. So there was some pushback on the part of clinicians in long-term care settings, and it was criticized. This statement of AMDA was criticized as hard paternalism, and it was felt that this position clashed with modern codes of medical ethics, which state that patient preferences should take precedence even when their decisions lead to death, and regardless of whether the person is terminally ill. So subsequently, these long-term care and post-acute care physicians were surveyed, and many, actually most of these physicians, stated that they believe that under certain circumstances, directives for said by AD should be honored. So 4 years after, in 2023, AMDA rescinded their earlier position statement, and they published a rather terse position statement at that time, basically saying it's an individual case-by-case process, and clinicians should consider all of the contexts, sort of clinical and biopsychosocial issues, and consider all of the context, the facility issues, local, state, and federal policy, and then make a decision. So one can kind of get a flavor that in long-term care, it's a hot button issue, and that seems understandable. And we're going to talk a little bit more about why that is. So by contrast, in home care, there's just kind of a different dynamic, and the key decisions about stopping eating and drinking are made by patients and family caregivers, and then the clinicians, the professional clinicians are brought in to assist as needed. And there is more flexibility to think about what would this person would have wanted, and also to include non-written evidence of the person's prior wishes for stopping eating and drinking, and to consider substituted judgment in the whole question. And then, by contrast, in long-term care facilities, that whole dynamic shifts. And there are daily decisions made by professionals in long-term care facilities, including nurses and aides and administrators, who are relying on facility protocols and their understanding of the regulatory and legal landscape. And so family decision makers, to be sure, are involved, but may end up playing a more advisory role in many cases. So having said all that, it doesn't exempt the home care caregivers from the legal issues that surround SAID by AD. As we have already alluded to, many staff in long-term care settings would struggle or even recoil at the prospect of withholding food and drink from a demented person who seems to exhibit enjoyment at being fed. And really the training of the bedside caregivers who are offering assisted hand feeding is to encourage food and drink, and even to be quite zealous about it. And for those who have observed the process of assisted hand feeding, it's really quite artfully done in many cases. And so if we are now saying that comfort-focused care is going to be different, and especially if we are expecting minimal comfort feeding, that's a different skill set. And where the training may include kind of coaxing or cajoling the person. And sometimes we see that even a little kind of shading over into coercion to eat could occur. So there needs to be consideration for the person and their training who is offering the assisted hand feeding. So now, how do we respond? So when a person with dementia worry is now considering hastening death, how do we help them navigate these choices, either preemption or relying on SAID by AD, or what? So I want to just touch on my mother's situation once more. So this is my mother 3 years after the whole family discussion happened. And I don't have time to explain the circumstances in detail, but this is the occasion of her, the 75th anniversary of when she would have graduated from high school, now receiving her diploma from that high school. It was a momentous and wonderful event that she would have missed if she had chosen to die by VSED or die by suicide 3 years earlier. So that is one example of the implications of these conversations. How do we approach them when people ask for hastened death? The general rubric that I'm proposing is, first, we have to listen. We have to understand the elements of the person's suffering and why they are asking now. So we might just directly say, I'm going to answer your request. But before I do so, it would really help me to understand why you were coming to me today asking for this, and then give them time and space, a safe container to respond. We then need to ensure that they clearly understand what dementing illness looks like going forward, how long they might live, what that might look like, or for any disease, to understand what the process looks like in their prognosis. We need to ensure the adequacy of palliative care, affirm our commitment of non-abandonment, assess decision-making capacity and to evaluate for potentially treatable causes that might affect capacity, such as depression that might result in an actual suicidal situation. And then we respond directly to their request after we have completed our due diligence and a multi-dimensional assessment. Of course, we must consider the legal limits and our own values without bringing our own moral judgments to impress those judgments on the patient. And we have a dilemma to bring colleagues in. But we're really trying to center the whole conversation on the person and what led to the inquiry. Now, when we're talking about bringing this rubric into the conversation with the demented person who is asking for an advanced directive for SED, it's really the same approach. Why are you considering stopping eating and drinking by advanced directive now? And we might ask questions to explore meaning and purpose. What is it that most gives your life meaning now? And if you think forward to the future, what are your thoughts on what might give your life meaning and purpose in the future? And see what they say. We're trying to identify any causes of suffering, either now or in the future, with an eye to remediation when possible. We may share that people with dementia often adjust, and we all have a remarkable capacity to adapt. And when we look at interviews and surveys of people who are living with dementia and their families and caregivers over time, we see that in many cases, the quality of life as judged by those individuals in many cases are good for years after diagnosis, especially in the mild to moderate stages of the dementia. We do need to provide that kind of education about the patient experience and also address misconceptions, such as overestimation of the degree to which freedoms might be lost, and also to highlight that enjoyment and appreciation is still possible in dementia, while also acknowledging people's valid concerns. And let's talk about those concerns. Dementia may threaten critical interests. Many people will say, I don't want my assets just going to pay for a long-term care and deal with attorneys. I want to save those assets for the people I love. I may not want to burden my family with the physical care or the decision-making or the responsibility for me. I value my autonomy and independence. I'm a proud, independent person, and I want my dignity. I want to preserve how others remember me, and I want to be remembered as I was. So when these issues come up, some of these folks may view preemption as their only valid and realistic strategies. And tragically, suicide is common, and we may not always appreciate how common it is. And several hundred people per year die by suicide in long-term care facilities, and I give the reference here. And so the whole point here, and I just want to underscore what I said before, some of these folks might prefer stopping eating and drinking by advanced directive if it could reasonably be assured that these directives would be implemented. So I want to stop here. I've got a couple of conclusion slides, but I think it's more important that we talk. So why don't I stop and take your questions?
Oh, Adam, we can't hear you.
But I was saying so many clever things. Can you hear me now?
Yes.
Yeah. Okay, can you hear me?
Yep, we can hear you, David.
Okay.
I was just thanking you for the talk, and I was reminding our participants, if you have a question, please put it in the chat. While folks are doing that, I'll start if I may. Sometimes I hear providers ask about the question of complacency. So if I have someone who comes to me and says, gosh, I worry about the future and I worry about my ability to control what my end of life looks like, what are the options available to me? Are we at a place where we consider VSED or VSED by advanced directive a common enough and acceptable enough occurrence that we should be discussing this, so that it is a viable option such that we should be discussing that option with these patients? I'm curious as your opinion about
Mhm.
that.
I would say it is not the first thing to offer. That has to be underscored that really this is an option of last resort. And so it falls into the same category as other options of last resort. Palliative sedation was at one time highly controversial, perhaps less so now. But to be sure, there are cultural variations from region to region and facility to facility. I can say that in settings such as mine, has become commonly accepted practice as a last resort option to raise the question when nothing else is working. And when we have few options that address the person's critical concerns, then we end up getting to a last resort option faster in a way, but we still have to go through the process that I outlined in the best practice of first understanding the reason for suffering and addressing all of the potentially remediable causes before we ever get to the discussion of the advanced directive for SED or VSED. Does that help?
Yes, I think it does for me, certainly. One question that's come up is if in your experience you find bedside providers excusing themselves from when
I'm
VSED by
having a
advanced.
little trouble hearing now.
I'm so sorry. This may be my own volume. Um, a question that came up is about conscientious objection, people excusing themselves from the care of patients, if this is something that has come up in your practice and how you've addressed it.
It has not come up recently. I work in a long-term care setting where we have had we have taken care to build a culture of specialization in these difficult situations that come at the end of life when nothing else is working. So palliative sedation is something we've been doing for 15 years. We have a policy and procedure for that. And we've had a few cases of VSED over the years, and we always talk about it. And we include our nurses and all of our professional disciplines before we move forward and make sure that we are offering people an opportunity to be heard. So early on, we had a case or two of conscientious objection around palliative sedation. But what I have found is that in recent years, those cases have not emerged. We have not in our long-term care unit had a case of SED by AD. So just to acknowledge that we don't have any experience with conscientious objection to that procedure. So it's still possible, but I think we have to make allowances as much as possible when people do object to be excused from participation. And that has its own challenges, especially if staffing is challenging, like on the night shift.
Thank you very much. Another question that's been posted, is there any momentum toward creating more state laws that either support or restrict stopping of eating and drinking by advance directive?
That's a great question. And I don't have my finger on the latest. What I can say is that Thaddeus Pope, who is one of the editors of the volume that I refer to in the reference list, a book that was published on VSED and said by AD in 2021. He really catalogs all of the developments as they occur and is probably the foremost expert on VSED and said by AD legal issues in the United States. So he is a very interested and accessible person. And so if you have serious questions about the legality, he might be a resource person to consider contacting.
All right. Question that came up was about the documentation requirements for these discussions. As you outlined it, they seem significant, right? A fair amount of coaching, making sure that we're kind of hitting relevant arguments. Any role for AI in this purpose of that, of that documentation of conversation?
I don't know whether AI has really advanced to the point where we can say it's validated in a situation like this and trustworthy. It might help to kind of expedite the process in a way, but I think it's really important to review the product, and this is why having a template is probably the safest place to really start from. I really advise you to go through the checklist that I included for here are the elements, and whatever document you end up using should have kind of a basic template to help the individual think through and respond to each of the critical elements of an AD for SED. So AI might be able to synthesize some of what a person is saying and kind of plug it in. Maybe that's the utility of the AI tool, but it doesn't avoid the need to carefully go back through the product and see if it actually answers all of the questions and does it well.
Curious about a word around to ask a question about language. When I have traditionally talked to patients and families about artificial hydration, nutrition, and a variety of terminal conditions, sometimes the word starving will come up, right? I feel like we're starving our loved one. And I was taught to take that word head on. Boy, starving implies that we're withholding food and drink from someone who is asking for it for your loved one with advanced cancer and organ disease or what have you. That's not what they're telling us. Their body's having a hard time processing it. And so I do put it in that context of comfort. And I think a lot of us were trained that way, right? Of offering food and drink when someone is asking for it as a comfort measure, but obviously guiding families in particular not to force. Our goal is not nutrition, it is comfort. I can imagine that the language is very different here when someone either verbally or non-verbally is indicating a willingness and an interest to eat. I'm curious if you've, if you've engaged it, how you've approached that, how you've worded that or sort of framed that, either for family members or for those bedside care providers.
Mm-hmm. Yeah, it's not unusual for us to encounter questions about nutrition and hydration in palliative care generally. And one of the things that we do in tackling that question head on is education around changing nutrition and hydration needs near the end of life. And for more straightforward scenarios, such as advanced cancer, we can point to the natural process of a loss of interest in food and drink near the end of life. I think what's different about SAID by AD is we're talking about a different scenario, especially when people seem to be accepting or even enjoying food and drink near the end of life. What we are saying there is we are trying to honor the personhood of the individual who, when they told us what they wanted for themselves, were very explicit. And so our role and what the person asked us to do was to be very thoughtful about how we're doing this. And so we have to acknowledge in this conversation that especially if the person is saying, I want to forego a comfort measure of CFO, comfort feeding only, then we acknowledge it could be uncomfortable for the individual. And here's what we will do to make it as comfortable as possible for the person. One of the things that I have heard from Barak Gaster, who some of you may know, authored a dementia directive that's pretty well known and widely implemented, is that if we withhold food first and allow sips of water, that might be kind of a compromise that makes it much easier for the person to tolerate. And so that might be kind of a nuance that could be offered in this process. And it will likely extend the period of time a person survives to some degree, but it may be much more easily tolerated. So it's the drinking that is actually most challenging to withhold. When people feel like I'm parched, I'm so thirsty. So if you still allow a sip here and there, maybe that is kind of a middle way that could be considered in addition to minimal comfort feeding. So other strategies that we might be able to talk about. And so this gets to the question of we can't just leave people on their own to implement the directive. We have to support people very significantly at the time we're doing it.
I'm struck by that need for support and need for expertise, a familiarity with this. I'm sure can be very, very comforting to those providers, right? This is a known entity. This is what we know about it. This is what has been written about it. Well, we are at the top of our hour. So once again, David, thank you so much for coming and talk to our group. This is really a fantastic talk. Several people have commented on that. We really appreciate you taking the time and talking to us about this important topic.
It's my pleasure. Thank you for asking me.
Right. Thank you, everyone, for joining us today. The recording of this presentation will be available. Thanks again, and everyone have a great day.